Welcome back to Child Mental Health for Pediatric Clinicians. I'm your host, Dr. Elise Fallucco, child psychiatrist and mom. I'm really excited to present this new series on deprescribing, which is the art and science of safely decreasing or stopping psychotropic medications in children and teens. In today's episode, we're going to be talking about what is the appropriate way to come off of medications, how quickly, how slowly, and if your patient develops symptoms while coming off of medications, how can you distinguish between whether those are due to relapse of the underlying condition versus a predictable transient experience of discontinuation, or rather the body and brain just getting adjusted to a lower dose of medication. And sometimes people refer to this latter one as withdrawal. And for this discussion, I'm very delighted to share that I'm joined by one of my favorite guests, Dr. Jeffrey Strawn. And you may remember him from some of our previous episodes, but just a brief recap, he is a professor of psychiatry at the University of Cincinnati, where he directs the UC Anxiety Disorders Research Program. And in addition to holding joint appointments in the Department of Pediatrics and Clinical and Translational Pharmacology. So one of the reasons why we love Dr. Strawn is because he not only is a research superstar as PI and co-PI of a number of studies, federally funded and privately funded, on anxiety disorders in kids, as well as treatment of anxiety with SSRIs and other meds, but he also has a very active clinical practice. And so what he does is he translates all of the cutting edge knowledge that he takes from his research studies to practical applications with patients and families. So please join me in welcoming Dr. Jeffrey Strawn.
You are too kind, and I am so excited to be back here. And I love what you just said at the end, because being in clinic, I think, is so important. And so many researchers, unfortunately, have to give up their clinics because of time commitments and other things. But what I find as a researcher is that my being in clinic reminds me where our treatments don't work, or maybe we can't predict certain things like side effects, or even, as we're probably going to talk about today, stopping medications, when that comes up, how to do it, and where the science really falls short.
Yeah, and where we need more of an art, and we need to try to push research. So I think clinical work informs research, and research informs clinical work, and it's beautiful when you can make it work. As you mentioned, one of the clinical issues that we face very often in practice is what's the best way to go about stopping medication or tapering down on a medication. And that brings us to your new book, Stahl's Deprescriber's Guide, recently published and co-authored by you and Stephen Stahl. And this book is truly a user-friendly guide to approaching deprescribing, which you define as either stopping a medication altogether or stopping a medication and starting a new medication. But I just wanted to ask you, why were you so excited to create this? I don't think there's anything like it out on the market. What motivated you to be a part of this? And what are you most excited to be able to provide to pediatric clinicians?
The real issue is we've spent so much time focusing on how we start medications. Yet, whenever we start a medication, our patients, their families, are wondering, is this indefinite? When will it stop? How will we know when it stops? Is my clinician going to stop the medication before I'm ready? What if I want to stop the medication? Will he or she be willing to stop the medication? And these are just things, unfortunately, that a lot of times, often because of the urgency that's there at the time when we're starting a medication, we don't fully discuss. And so I think, again, as a field, we've not spent a lot of time thinking about how to stop medications or how to change course when a treatment's been successful, or perhaps when it's stopped helping, or maybe when it's created tolerability concerns. Over time, my hope is that deprescribing will be normalized and certainly not politicized. Over time, I hope that we'll see clear medication-specific guidance and hopefully better integration with shared decision-making. And those are really some of the things that were important for us to think about as we started the writing of the book and even the conceptualization of it.
You just mentioned shared decision-making, and that reminds me of an important point that you bring up in the book, which is that we as clinicians are not the only deprescribers, that in fact, there are a lot of times in which our patients themselves deprescribe for a number of reasons.
I think really when we think about who is a deprescriber, it's all of us, right? It's you. If you stop a medicine that's not working or that a patient is experiencing side effects and you need to switch to another medication, or you're switching from one that's maybe not working to one that you hope will work better, and how do we deprescribe the one slowly as we're starting the next one? But I think our patients are also deprescribers in terms of when they miss a dose of a medication, or perhaps they're taking an adjunctive medication that they just start forgetting to fill, or they may go on a sleepover or summer camp and forget the medication. So I think there are lots of things that actually happen where we are all deprescribers. In fact, any prescriber is a deprescriber. Now, obviously, this has taken on a lot more of a charged flavor recently in terms of, some things that are coming out in the media and, also in different groups, Facebook groups and on the internet, in terms of deprescribing what it is, what it isn't, and things like that. So it unfortunately has become a bit charged. However, in parallel with that, we're seeing a lot more attention being paid to this in the scientific literature. We're seeing meta-analyses of discontinuation symptoms with the SSRIs, for example. We're seeing books like ours that have come out on deprescribing. And actually, just recently, there was a really nice article published just last week on deprescribing that was sponsored by the American Society of Clinical Psychopharmacology.
I'm so glad that people are paying increased attention to the concept of deprescribing, because it felt like for the longest time we were so focused on initiating meds. Which meds do you choose? What's the appropriate dosing? And there's much less attention paid to when do you stop? And most importantly, how do you stop? What is the safest and most effective way that minimizes symptoms for the patient?
Absolutely. I think the other thing in terms of writing the book is we often don't think about the psychological aspects of starting and stopping medication. And as somebody that is interested in anxiety disorders, this is something that I really, really felt was very, very important to include, because this is something that comes up in every discussion that I've ever had about stopping a medication or cross-titrating a medication.
And I would say, particularly in people who do have anxiety disorders, I think it is much more fraught, the idea of we're going to switch meds. And even if we're not talking about anxiety meds, I'm thinking about my patients with, anxiety and comorbid ADHD. When we're talking about switching from different stimulants, there's a huge reluctance on the part of the patient with anxiety because they're thinking, I don't like change. I like to know what to expect. And with change comes uncertainty.
Absolutely. And I think you really hit the nail on the head there in terms of we often in the anxiety disorders world think about this construct of intolerance of uncertainty. And I think that's something that's really, brought to the forefront when we're talking about stopping medication or when we're thinking about cross-titrating a medication.
Yeah. And I'm thinking of one of my patients, one of my teenage boy patients with OCD and comorbid generalized anxiety and social anxiety. And I think we had tried an SSRI and we had maximized the dose, and we just felt, with the family, it wasn't effective and we really needed to do a second trial. And I remember we just got stuck on that first dose for so long because the patient just hated the idea. He could acknowledge like his OCD symptoms were not great and not well controlled, and his underlying social anxiety was still poorly controlled, but he thought, I will just work around and I'm not going to go to restaurants and I'm not going to order in front of people and I'm going to avoid any particular social situations because I'm so scared of coming off of a med that's not even that effective, because what happens if the next one doesn't work? Or what if it makes me even worse? I'd rather take this level of discomfort.
No, and that's a great case. And it really illustrates perhaps how we can maybe make that decision or that discussion around medication and exposure, right? Which is something that we know is the goal of our therapy for OCD, as well as for most of the anxiety disorders. So essentially tolerating the uncertainty or treating that as a distress tolerance exposure.
Oh, I like that. Getting your psychotherapeutic skills more involved in that. But in the case of this OCD patient, and honestly, in the case of most patients in general, there's two major real fears that you face when tapering off or stopping a medication. And the first is that you might have some sort of relapse, that the anxiety or depression or ADHD or whichever condition you're treating will come back once you are no longer on medication. So there's the risk of relapse. And then the second risk with certain particular meds, and I'm thinking about the SSRIs in this case, is the risk of developing discontinuation syndrome, or what is sometimes referred to as withdrawal. And in your book, The Deprescriber's Guide, you have some great tables that lay out very clearly how you can distinguish between relapse of symptoms versus withdrawal or discontinuation. And to anchor this to a clinical example, let's say we have a teenage female patient with anxiety who's treated with an SSRI for about a year, has had a really positive response, has also engaged in cognitive behavioral therapy, and the family says, I think we're ready to come off of the medication. I think we learned the skills we need to know in therapy, and let's try to come off of the medication and see, do we really need it? Now, if this patient were to develop any symptoms in the process of coming off of this medication, how do you distinguish whether this is normal discontinuation versus a relapse of the anxiety and a sign that perhaps she needs to go back on the medication?
So this issue of how do we distinguish withdrawal from relapse in clinical practice is so unbelievably important. Now, in practice, I think we focus largely on timing, number one, symptom pattern, number two, and trajectory, number three. So symptoms that emerge pretty quickly or after a dose reduction or fluctuate in a day or perhaps include features that the patient has never had before, that's easy. Those are more suggestive of discontinuation effects. We can also look at some things from a really nice meta-analysis that was recently published in July of this past year, of 2025, looking at antidepressant-related discontinuation symptoms in patients with depression or anxiety disorders. Now, again, this is a study that was done in adults, but I think it's still something that can give us some insight because they found that there were a couple of symptoms that actually tended to have more specificity with regard to withdrawal. The other thing that I think is important for clinicians to look at is what are the symptoms that really resemble the original illness that we were treated or that worsen over time? So again, something that's worsening over 4 to 6 weeks after a dose decrease or stopping the medication versus something that emerges over a week or so. Now, I think the other piece is that we tend to rely pretty heavily on measurement-based care and a lot of functional outcomes, not just symptom descriptions. And sometimes I think the only way to clarify the picture is to pause the taper, to slow it down, or even in the case where we're stopping sertraline entirely, to reinstate an earlier dose and see what happens. So again, really using time as our stethoscope here.
That's excellent. I'm going to try to summarize in a little bit. Like if you imagine distinguishing SSRI withdrawal from relapse of underlying, let's say, anxiety or depression, the first thing that you want to think about is timing. And you would see withdrawal symptoms fairly immediately after the first dose reduction in terms of days.
Within several days, generally.
Whereas you wouldn't expect relapse of the underlying illness to occur that quickly.
That's generally the case. And then again, there are some of those symptoms that are much more specific to withdrawal.
Right. I'm thinking about the zaps. I personally went through a too abrupt discontinuation of a medication and physically got to experience what they call the brain zaps. And It is wildly uncomfortable and resembles nothing like underlying anxiety or depression.
Right. So those dysesthesias and the dizziness tended to be the two most specific, although certainly the other flu-like symptoms that we have all been taught about are there as well. But in the meta-analysis, that dysesthesia that you've just very nicely described, and also the dizziness sometimes tended to be a little bit more specific.
I was living in Boston at the time and trying to rollerblade around the Charles River. And I remember this really distinctly because anytime I would move my head really quickly, I would feel sort of dizzy, but in a different way. My eyes moved quicker than my brain did. And it took my brain a little bit of time to catch up and sort of see where I was in space, which did not end well.
I'm sure.
Back to the 3 criteria to distinguish withdrawal from relapse. So 1 is the timing with withdrawal symptoms occurring very rapidly. 2, we talked about the symptom pattern and how certain symptoms like the dysesthesia, brain zaps, dizziness are much more specific for withdrawal and obviously very different from underlying symptoms of anxiety or depression that you would see in relapse. And then 3, the trajectory. You made an excellent point about how if the symptoms are related to withdrawal, then what you would expect is that, assuming that you're not continuing to decrease the dose over time, if you just pause and stay at that dose, that ideally over time the symptoms should get better. If it's related to underlying relapse of the illness, staying on the current dose, if it is inadequate to treat the illness, the symptoms would worsen over time.
I think that's put perfectly.
And just to emphasize why this is so important to distinguish between withdrawal and relapse, if a patient is experiencing withdrawal symptoms and we pause and we notice that the symptoms get better when we just hold the dose at a given number, then the way you'd respond is more slowly tapering off of the medication over time to give the body and the brain more time to adjust to these changes. Whereas on the other hand, if a patient is coming off of medication and develops relapse, then that's a sign that we likely need to continue the medication at least at the current dose and perhaps eventually get back to the original dose that the patient was on before the trial taper. All right, well, we're going to put a pause on this conversation now, but I promise we will continue talking with Dr. Strawn in the next episode, where we're going to focus on the best way to switch between SSRI medications and the various strategies you can use, the pros and cons of each one. If you have any questions about this particular topic, feel free to write back to our newsletter or to check out our website, psych4peds.com, and we will try to answer your questions on air. Thank you for joining us, and we'll see you next week.